This is Julie Cox. Thank you for joining this afternoon's webinar with Dr. Cox. This is the first of a series that Dr. Cox has been planning based on conditions of the spine and writing out guidelines that can kind of direct the protocols as you apply them per each condition. So this is our first one. And I want you to know too that there are notes. If you look in your panel that is on your screen right now, look at handouts. It says 1 of 5. If you click on that, you can download the notes for today. It also has that new list of guided protocols that you can implement as you would desire. Today's webinar will be a short one. We're not looking to be too long. Midway through, we'll switch from slides over to the table so you can see Dr. Cox demonstrating protocols, and that's kind of the plan for today. So without any further information, and also know that if you have questions today, please go to the question box, type those in, and I will ask those of him at the appropriate time or at the end of today's webinar. So questions are welcome, the handouts are there, and I'm going to turn this now over to Dr. James Cox, developer of Cox Technic, and today's first webinar in this series.
Thank you. These are meant to be succinct illustrations and demonstrations of the non-surgical treatment of specific spinal conditions utilizing Cox distraction spine manipulation. The first 2 slides I will not go over in great detail. They are yours. You can study them. They are the protocols from A to Z of how to utilize our work. And you will see that we will be treating 2 ways, with and without the occipital restraint, in order to treat both protocol 1 and protocol 2. Primarily, we're interested in protocol 2 because this is cervical spondylosis, not necessarily disc herniation or spinal stenosis. I will be covering these points, and I want you to note, if you would, please, that I will share with you the difference between 2, 4, and 6 pounds of distractive force on specific cervical and upper thoracic segments. We will be used both with and without occipital restraint. I wanted to cover just a couple papers that highlight and excite the meaning of this podcast to you. Number 1, this paper just came out January 26th this year in Musculoskeletal Science Practice. It's pointing out that the technique we use, how is it effective in treating headaches, for example? And this pointed out 3 management strategies that we will cover: upper cervical spine mobilization to treat cervicogenic headache, active mobilization exercises, and lifestyle advice. We will be covering the exactness of distraction of the cervical spine and upper thoracic spine, and then the afferentation of range of motion restoration to each of these spinal segments. Yes, this is a non-surgical treatment. It is different than high velocity in that it uses low velocity, variable amplitude manipulation and mobilization of each cervical segment. I'd like to call your attention to one of the most exciting papers I have seen, and it's from January 25 this year in Spine Journal. You may have seen it. This was that only spinal manipulation induced immediate improvement in parasympathetic activity to the heart. Yes, the alterations in heart rate variability by manipulation of the upper thoracic spine. You will see us do that. This is one thing I'm sure you will carry with you from this seminar. Incidentally, I've given you the notes so you can study these papers on your own. When we look at the work of Onifer et al. At Palmer, published in the Evidence-Based Complementary and Alternative Medicine journal, you can see that in the study of the human versus the Worcester rat, and this paper was published here about neuropathic pain relief with Cox Technic. And in this study, it shows the adjacent segment motion that is performed And these are the illustrations, the top showing a human. Then we made the Cox Table at the University of Iowa. We built it 1/12 the size of the instrument that you use in doing this technique in your practice each day. And we use it to treat the big Worcester rat in order to test the changes in the osteoligamentous canal, the vertebral disc space, when we perform Cox technique. So we look at the work of Chow. His conclusion, published here in Musculoskeletal Science Practice, is that horizontal traction is evidently effective in increasing the disc height in the lower lumbar levels, the areas that you and I treat all day as clinicians. It is important that we relieve spinal stenosis in protocol 1 radicular patient, moving on to protocol 2 if they don't have radicular pain or the radicular patient attains 50% improvement. This is an important paper to document why we practice as we do. Young wrote this paper in 2019, pointing out that one session, as we will illustrate, one session of thoracic manipulation may result in improvement in pain disability, return of range of motion to the cervical spine, and deep neck flexor muscle endurance. These are things that you and I think about when we perform this technique. And then briefly, think about this powerful papers that I'll share, these three. First done by Jun et al. In the Chiropractic Manual Therapy, that says that from these articles, the themes identified with respect to the potential mechanisms of how this work benefits our patient. Number one, there's a change in muscle activity. 2, increased mobility. 3, decreased pain. 4, increase the pressure pain threshold. That is, you can tolerate more PPT. A change in spinal tissue behavior. And then lastly, the change in the central nervous system or reflex changes. Put another way, Goodavali, Cox, Cruz, and Olding and Yoakum at the Loyola Medical Center and Hines VA Hospital said there are 5 things that happen when you perform Cox distraction manipulation. We increase disc space height, we drop intradiscal pressure, we increase foraminal area, we restore and maximize range of motion, and then we create afferentation by the lateral spinal thalamic tracts to stimulate by a functional MRI the structures of the brain to create corticospinal return of pain relief. And put another way, these are the things that must take place in the literature today for a patient to receive relief of both pain and disability from a spinal manipulation. Wong wrote, we must increase range of motion. We must strengthen muscles. Beate said we must stimulate circulation through the cancellous vertebral body, through the end plate, into the nucleus. Kuo states that traction treatment is effective in enhancing nutrient supply. And get, these are the words of Kuo, promoting disc cell proliferation of degraded, degenerated discs. That's why we use Discat Enhanced. This is chondroitin and glucosamine sulfate that are the building blocks of white fibrocartilage and nuclear material. And then Chung showed that when you separate the spine under distraction, that you change the disc shape, you reduce the intervertebral disc herniation, you separate the disc from the adjoining nerve roots, and you widen the facet joint space. So as we move to show these movements with the instrument, I want you to note these are cases that you and I see daily as clinical practitioners: degenerative disc disease, reversed lordotic curve, loss of range of motion, neural compression, pain in the neck, shoulders, and arms. And not only will we show the treatment of these conditions under distraction, but we'll also discuss the treatment of specific segmental dysfunction, the anterolisthesis, the retrolisthesis, the rotatory subluxations that occur within the human spine. With this in mind, we will move to the instrument and demonstrate the technique. So when we treat these conditions, the degenerative disc that we saw, the various types of segmental dysfunction, subluxation, here's how it will start. I'd like you to know 2, 4, and 6 pounds of individual triple joint complex distraction force. Tolerance testing. Start with the foramen magnum pump, basi-occiput, long y-axis distraction. We test each segment of the cervical spine. I ask my patient, tell me if this creates any increased neck pain, shoulder or arm pain, as I distract each segment all the way down to T5. The patients, once they've been tolerance tested, we begin, and I will start with you with a C5 level treatment. The most common disc degeneration, most common stenotic segment that we see. Basi-occiput here, I contact C5. By moving this hand and the tiller bar cephalward, if you'll watch the graph, you'll see that the first thing I do is attain tautness. We call that the barrier of elastic resistance. If you watch the blue line at the top, you'll see it rise. I've now taken all the slack and I've reached a taut point from which we will attain flexion distraction. And I'd like you to note that 7 pounds on the right, if I just increase that to 2 pounds, that's 2 pounds of distraction force. Always start at the low 2 pounds of distraction. That's what it looks like. For many of you, you have to practice to be this gentle. If this gives the patient relief, this is what you will use. Then as they respond, you can increase that to 4 pounds via V. If you watch the chart, I go from 6 to 10 pounds. I've doubled that. And I say, are you okay? Does that feel okay to you, patient? And if that works, if you want to go to 6, and I rarely ever go this high, any higher than 4, but here would be 6. If you look from 6, and I push up to 12 pounds, that's a lot of force, and the patient will tell you that. I rarely go this heavy. 2 to 4 pounds. Whatever gives the relief with the least amount of force, that's where we treat. This contact hand can increase or decrease cervical lordosis. As the patient responds and they have the kyphotic sagittal curve, I can increase the PA force to bring back a lordotic curve. I can even release the flexion extension lever and distract and move the headpiece into extension in order to create a physiological lordotic cervical spine. Then, the foramen magnum pump, a technique that we use on every patient. At the beginning is tolerance testing, at the end is a treatment. The basi-occiput here, full spine distraction here. And you'll note the pounds. At 2 pounds, you can build to 4, you can build to 6. Now many of you, in order to learn these forces, you've been to didactics with us where we have you work with this instrument, with this computerized force to learn and attain this amount of pressure, okay? Now, upper thoracic, we mentioned the work of Rodriguez before about the effect on heart rate variability. The upper thoracic's being sympathetic innervation. You and I are very interested in relaxing sympathetics as we stimulate what? Vagal parasympathetics. In the upper thoracic spine, we will perform lateral flexion into both sides in order to relax the sympathetic nervous system, the regulators of heart rhythm, respiration. Read the work of Rodriguez, for example. So we can do this manually, or next we will move to the complete range of motion, so that if we have distracted and the patient tolerates it, we will use distraction again at the C5 level. I distract and now laterally flex, lifting C5 on C6, placing it into both right and left lateral flexion. And you'll note, please, that we are using distraction first in order to reduce any stenotic effect as we apply long y-axis and lateral flexion. Then we apply long y-axis and rotation. And it is at this benefit that we reduce segmental dysfunction subluxations. For example, if I have a patient with a retrolisthesis of C5, I will take C5, distract, and use flexion to reduce the C5 retrolisthesis. If it is a C5 spondylolisthesis, a forward, I'll come down and contact C6, distract, and extend C5 on C6. If it is a C2 right posterior rotation subluxation, which you know is a very common lesion that you and I treat for, say, headaches, neck pain, we will contact C2, apply long y-axis distraction, derotate, and distract in a smooth, coupled, rhythmical pattern. Protocol 2, which many of you know and many of you may be excited and urged to learn. Now, we also use occipital restraints, and some people prefer occipital restraint. You bring it over, it attaches under the headpiece. When you bring the other one over, where they cross will be the distraction fulcrum. And we can treat the cervical spine by contacting T1, applying distraction at each segment up to C5. We can move down into the thoracic spine with long y-axis distraction. For example, in both treating thoracic disc herniations and to relax this upper thoracic spine as we did without occipital restraint. But with them, I can place my thenar edge against the convexity of a curve or do both sides together, create long y-axis distraction, rotation, and lateral flexion into the right and left side of the upper thoracic spine. Remember that upper thoracic manipulation has been shown in the literature to increase cervical range of motion better than the actual treatment of the cervical spine itself. So when you and I do both, we have a pretty powerful weapon with Cox Technique. Now, following complete range of motion, we will lock the instrument, and you will soon learn that one of the great benefits is to adjust the spine under distraction. That is, you will make the contact. You'll see that I'm using the lower extremity, the caudal section, to apply distraction. Make the contact, no thrust. Let the distraction increase the disc space, drop the intradiscal pressure, increase the foraminal area, and as we do this, we will get cavitation. As long as there's any nitrogen gas in the facet. And listen, please know, there are many patients, as you know, who they will give you some resistance to high velocity thrust. They will not resist this because there is no thrust. This is low velocity, variable amplitude adjusting. And in many of your patients, you'll get more cavitation with the gentle technique than with the strong technique. As I end this, I'd like to make a comment to you. I have had doctors who are very interested in this type of work. Those doctors are not only chiropractors, but they're PTs and DOs and even MDs. What I'd like to offer to you is, if you're really interested in this, and you'd like to spend time with me personally, on a one-on-one basis. Just contact me about that. This concludes my short version of cervical upper thoracic spine manipulation with Cox distraction technique.
If there are any questions, please send those in. But in the meantime, while you're populating questions, know that our next webinar and topic will be March 3rd, degenerative scoliosis, March 17th, lumbar spine spondylosis. And if you want to study online, we have our online learning management system for CE credits. There are several courses on cervical spine. The textbook is also at your service. And know that we have workshops, online CE, and live courses. We are planning live courses. Our next one we're gearing up for is the part 4 brand new thoracic spine course, April 17, 18. Then we're doing the lumbar 1 and 2 here in Fort Wayne, the end of April 29 to May 2. And know that the Force Table is by Haven Medical. Their engineers have designed all of this wonderful equipment that helps us train and also you to show patients what's going on in their spine. Patients are really interested. Check with Amanda on that. We look forward to seeing you at our next webinar. And those are all of our contacts. And I don't see a question just came in. Let me check that real quick. Let's see what's there. Nope, a nice thank you, Dr. Cox. So there you go. All right, well, thank you so much for joining us today. Be sure you get your handouts downloaded, and we look forward to seeing you on March 3rd. Have a great afternoon. I'm sure you'll see some cervical spine patients today.